Thank you very much, Ashraf. Just to check that everything is okay, you can hear me and you can see my presentation, right?
Yeah, we can hear you and we see it very nicely.
Okay, so we go on with the assessment of preload responsiveness in non-mechanically ventilated patients, and we will see some specific situations as well where the prediction might differ from the other cases. We have seen before the respiratory variation of the peak velocity in the LV outflow tract, as VC and Professor Daniel de Backer insisted on that later. And we spoke about the end-expiratory and end-inspiratory occlusion tests. These three tests and indices worked for ventilated patients. The first other test that may be useful in non-ventilated patients is the classical fluid challenge. I mean, infusing 300 to 500 milliliters of fluid, check the response, and if it's positive, go on with fluid administration. Of course, it's very easy to perform. You just have to give fluid to the patient and look at the answer, at the response. Nevertheless, two major drawbacks. The first one is that, bear in mind, to properly assess the effects of a fluid challenge, you need a direct measurement of cardiac output. I mean, you cannot do that properly just looking at arterial pressure. Even the pulse pressure, systolic minus diastolic, which is normally related to stroke volume, it's not precise enough for assessing the effects of a fluid challenge on cardiac output. Just to illustrate that, a study by the team of Jean-Louis Vincent and Daniel de Backer. Patients received 500 milliliters fluid. Cardiac output was measured before and after, and blood pressure measured before and after. You see there was no correlation at all. We performed a similar study where it was not correlated, but at least very poorly correlated. At least it tells us that to properly assess the effects of fluid and of that fluid challenge on cardiac output, we need something, an assessment of cardiac output that is more precise than the simple blood pressure of the bedside monitor. The second drawback of the classical fluid challenge is that it inherently induces fluid overload, the fluid overload we want to avoid in the most severe patients. Why? It's inherent to the method. What is the fluid challenge? You give 500 or 300 milliliters of fluid. If the patient responds to an increase in cardiac output, you go on until the last challenge that is negative. The problem is that once you have given fluid, it's not possible to remove it from the patient. Let's imagine a patient with septic shock on first day with ARDS. You will agree with me, this patient will experience perhaps 5 or 4 episodes of hypertension. What means that at the end of the day, the patient will have received a significant amount of fluid that did not increase cardiac output inherently to the test, but that increased the total fluid administered and increased the fluid overload. I mean also that the fluid challenge, it is not a challenge, it is the test itself. It's the treatment itself. It's not a test. You give 500 milliliters of fluid, you give the fluid you want to give in that patient. So it's not a prediction, it's the test itself. This is why the mini fluid challenge might be something interesting. Indeed, it consists in giving not 500 milliliters, but less, 100, 150. So, of course, it may induce fluid overload, but less fluid overload. And since the first study that was published in 2011, we have some more and more positive studies. My point here is that it is reliable, but you need a very precise measurement of cardiac output to assess the response to that mini fluid challenge. Look, this was the first study published by some French colleagues in 2011, and you see that the response of VTI measured with echo to a 100 milliliter fluid challenge differentiated responders and non-responders, predicted fluid responsiveness nicely. But of course, small volumes of fluid can only induce small changes in cardiac output that were detected in that study with echocardiography. Is echocardiography precise enough for detecting so small changes in cardiac output? Likely not. This is a study we published last year, looking at the precision of echocardiography. Look, for the velocity time integral, the one you measure every day in your patients, the smallest change that corresponded to a true change that could be trusted as a change was a 10% change. It means that if VTI changes by a lesser extent, you're not sure it's not due to an error in measurement. The smallest change you may trust in VTI is 10%. This is why the effect of that mini fluid challenge, I think, might be too small for being detected safely with echocardiography. Again, if you have another means for measuring cardiac output, like for instance pulse control analysis, with a very, very precise technique, a very small detectable change, 1%, it might be more reliable and easier to perform. So the mini fluid challenge with echo, perhaps, but be sure of the precision of your measurement, and you must be, let's say, a quite skilled echocardiographiist, I think, for assessing that precisely. And in any way, it still consists in giving fluid that you cannot remove from the patient. The passive leg raising test, in fact, is like a fluid challenge, but without a drop of fluid infused to the patient. You know, it's been today well demonstrated. I don't enter in the details of the pathophysiology of the test, of all the confirming studies, etc. It's well demonstrated. My point here is that to perform the passive leg raising test, you need a direct measurement of cardiac output, like by the way, for the classical fluid challenge. For the pseudo fluid challenge, which is passive leg raising, it's the same. You cannot assess it precisely by blood pressure, even by blood pulse pressure. It's been shown by many studies. This is the meta-analysis we published now years ago with all the studies published at that time. Look, the area under the ROC curve was very good on the left panel when the changes induced by passive leg raising were measured with cardiac output. Why? If the studies looked at the changes with arterial pressure, the area was less. And especially there were some false negative cases. It means that the patient did not respond on blood pressure to passive leg raising while they responded to fluid administration, false negatives. It means that in that circumstance, just like during the classical fluid challenge, a precise assessment of the response requires a direct measurement of cardiac output, and of course, it is one of the drawbacks of passive leg raising. So for the last years, the main question with passive leg raising has been which techniques could we use for assessing cardiac output changes, since we cannot use arterial pressure. We have summarized that in some reviews, but you can use pulse contour analysis with the same technique, for instance, I showed during the end expiratory occlusion. It's very easy, just have to look at a screen. Nevertheless, all the patients are not equipped with such monitors. You can use esophageal Doppler, not very easy. By the way, the first study we published in 2006 was performed with esophageal Doppler. The majority of the studies performed about passive leg raising were done with echocardiography. And with echocardiography, the surrogate of cardiac output you may use is the velocity time integral, because you know that the VTI in the LV outflow tract is proportional to stroke volume. You even don't have to measure cardiac output, since you look at relative changes. You don't have to measure the diameter of the aortic root. You just have to look and measure the changes, the relative changes in VTI. Provided that you are sure that the flow remained exactly in the same position in the echo beam, you know that the changes in VTI are proportional to the changes in stroke volume. And so since the threshold for positivity of passive leg raising is a 10% increase, if VTI increases by more than 10%, you know the test is positive. It's been shown, for instance, in that study years ago, the threshold was not far from 10, it was 12%. I think that 10 is in fact the true threshold. Is it possible to use something else with echocardiography? Yes, because you know VTI is not very easy to measure in all the patients. Something that is perhaps easier to look at, especially in non-echogenic patients, might be the changes in the IVC with ventilation, the relative changes. And you may think that during a positive passive leg raising test, if the test is positive, the IVC should decrease, like it would happen with fluid infusion. The patient becomes less fluid responsive during the test. And so if this is true, if this hypothesis is true, it means that a decrease in IVC changes during passive leg raising may indicate a positive test. Unfortunately, it's not very good. This is what we show in that study I quoted before, which is under review, so be careful with these results. The study is not published, but just to show you that the area under the RUC curve for the passive leg raising induced changes in the IVC was not very good. And likely because the reproducibility of that IVC changes measurement was not that good. By contrast, look, if you have an A-line, the changes in PPV during passive leg raising, based on the same hypothesis, decrease in fluid responsiveness indicates preload responsiveness, the area under the RUC curve were good, either measured in absolute value, either measured in percent changes. You see that the area was much better than with the IVC respiratory changes. So it means that for assessing the changes in cardiac output with echocardiography, look at the changes in VTI. There are many other techniques that can be used for assessing the effects of passive leg raising. I don't show all the studies showing that, describing that. I just would like to quote, just by speaking, a study we published where we showed that the changes just in the SpO2 signal, the PLET signal, indicated a positive passive leg raising test. The changes in the perfusion index, so a very simple non-invasive signal that is present in all our patients during passive leg raising, indicated a positive passive leg raising test, and it was a very good, very nice surrogate of cardiac output. This needs to be confirmed, but something likely interesting. Passive leg raising and just an SpO2 sensor. Regarding the drawbacks, so still you need to measure cardiac output or a surrogate in a way, in any way you do. And I would like finally to insist on the issue of intra-abdominal hypertension, because it's been suspected that in case of intra-abdominal hypertension, the passive leg raising test would be less reliable and there would be some false negatives. Why? It is quite easy to understand that if there is a high intra-abdominal pressure, the splanchnic compartment, the splanchnic blood volume is reduced. But we know that a large part of the effects of passive leg raising are due to the blood contained in the splanchnic compartment, in the abdomen. It's not only the blood contained in the legs, it's also the blood in the inferior limbs. It's also blood contained in the splanchnic compartment. And so if that volume of blood is reduced because it's crushed by the intra-abdominal hypertension, the hemodynamic effects of passive leg raising might be less. For years, it's been only suspected, but in that study we published last year, we showed it is actually the case. We included patients with and without intra-abdominal hypertension. In all the patients, we performed a passive leg raising test and then a fluid infusion. And look, in patients without intra-abdominal hypertension, volume expansion increased cardiac output, and passive leg raising test did so to a lesser extent. You know that, perhaps you don't know, I don't know, that the volume of blood mobilized during passive leg raising corresponds to around 300 milliliters of fluid. But in patients with intra-abdominal hypertension, the response to fluid was the same, but the response to PLR was less. In case of intra-abdominal hypertension, passive leg raising has less effect on cardiac output. And of course, this induces false negatives to the test. In the same study, when we classified patients between responders and not responders, we observed some patients who were going to respond to fluid, but with a negative passive leg raising test. It was not all the patients, some false negatives, but of course, it is a drawback of passive leg raising, and yes, it is the case. Nevertheless, passive leg raising can be interpreted in a large rate of patients, in a large proportion of patients. I quoted before a study where we showed that PPV can be used in only 17% of the patients. Look here, passive leg raising could be used in 66% of the patients, so it might be something interesting. So to summarize, we have seen that in non-mechanically ventilated patients, but also in ventilated patients, we can use the mini fluid challenge and the passive leg raising test. Both might be assessed with echocardiography. But for the mini fluid challenge, you need to be very accurate when you measure the VTI. Be careful. With passive leg raising, since the effects are larger, you look at the changes in VTI with being quite confident because the changes are larger. You need to be precise, but not as much as for the mini fluid challenge. And you bear in mind all the drawbacks of passive leg raising, especially in case of intra-abdominal hypertension. And with this last message, I thank you very much for your very kind attention.
Thank you very much, Professor Xavier. It was a very nice presentation as usual. And it carries maybe a lot of points to discuss, but the time maybe is not gonna allow us for more than one or two questions. I have here a question from one of our colleagues is questioning why should we go, I don't understand well the question, but let me read it for you.
Mm-hmm.
He's talking about the passive leg raising. When we raise the lower half, including the lower limbs, and then we push around 300 ml of blood to the heart, and this is assumed to increase the preload. He's asking, why should we do this if we can do something else like using the pneumatic devices versus no in immobilized lower limb, and see if would increase the cardiac output or the, I don't know, if you have any comment on this suggestion, let's say.
Can you repeat instead?
Yeah, he's asking, instead of doing the procedure of passive leg raising,
Mm-hmm.
can this be also induced by some sort of compression on the lower limb, by pneumatic compression, without raising the legs, without doing this?
Right.
Yeah.
It's a very good idea. It should be possible, just a pneumatic compression of the inferior limbs and of the pelvis, for instance. It should work. The problem is to know which is the threshold of increase in cardiac output that could be considered as positive. We are nowadays performing such a study. Also, you need a device that's adapted for compressing not only the legs, but all the inferior limbs. We have built such a device. We are performing the study, so I could give you the answer next year, but it's a very good idea. And of course, if it worked, it would mean that it would be much easier to perform rather than lifting the legs and moving the patient. Just have to push on a button to compress the legs. It's a very good idea. Thank you.
Great. So let me allow Dr. Walid Al-Habashi to ask a question. He has a question to Xavier.
Thanks very much for giving me the chance. Professor Xavier, in theory, or I read it in some literature, that this way of doing passive leg raise test may compress the femoral vessels and may cause some pain in ICU patient population. So with this stress-induced reflex may increase the heart rate, and this will increase the cardiac output, or compress the femoral vessels, and this passive leg raise test comes of no value towards the end, which gives fallacies of the test. How do you interpret this one?
Thank you very much for the question, Walid, because and to the colleague who asked the question, because it's a very important point. It is true that if it is not well performed, passive leg raising may induce some pain. That's why it's very important to do that, not by lifting the legs, but by moving automatically the bed from the semi-recumbent position to the passive leg raised position. And in this way, you don't move the hip angle. And so you avoid that pain created by moving moving the hip angle, by touching the heels of the patient, by moving the femoral catheters, etc. Also, you must tell the patient, if he or she is conscious, you should tell him or her that what you are going to do to avoid any surprise. And finally, to be sure that the change has not been induced by just pain or waking up of the patient, just measure cardiac output after the test. It must come back to the initial value in the semi-recumbent position. If it doesn't, it means that something else has happened, like, for instance, pain, etc. For a good test, cardiac output may increase, but then decrease to the initial value when you put the patient back in the semi-recumbent position. So I agree that it's not that easy. It's a reliable test that might be used in many patients, but it's not that easy. That's why some easier solutions are interesting.
We have a question here from one of our colleagues. He's asking, is the time makes any difference when the patient present early with shock or they present late with shock, i.e., they're coming to ICU after a bit of time and then they were shocked, remaining shocked. Fluid responsiveness, early in shock versus late in shock, is there any difference?
It's a very important point again. You can use the same test at the beginning of the initial or late phase, but the probability of fluid responsiveness is not the same. As I said at the beginning, and hello to your cat, by the way. He or she is really very, very beautiful.
Okay.
If it's a guy or
a guy, yeah.
Okay, so he's very interested in cardiography.
Fluid responsiveness.
Very. As I said, bear in mind that initially all patients, septic patients, respond to fluid. All hypovolemic patients respond to fluid. Many cardiogenic shock patients, not all of them, respond to fluid. Then, for instance, for septic shock, initially don't attempt to predict fluid responsiveness. Just give fluid without any prediction. That's very important. Don't waste time for that. But after that, when fluid responsiveness becomes less likely because the patient has already received some fluid, then you must predict fluid responsiveness. So it's a very important point, and thank you to our colleague for the question.
Thank you very much. Hisham, do you have a question to Daniel? Or?
Just regarding the 10% change in the VTI, Professor Xavier, don't you think this is very little? Because if you get two operators and they can do just a few minutes in between, you can find such change in measuring the VTI. So don't think this 10% increase as a response is a bit of low threshold?
Of course, it's a thank you. Of course, it's a threshold. It means that many patients have a larger change than 10%. But it's the threshold. It might be as low as 10%. Regarding that issue, I agree that you must not waste time between the two measurements. And my advice is that you should keep the probe on the patient when performing passive leg raising. You measure cardiac output, you perform the test, but you keep the echo beam exactly at the same place, and then you measure cardiac output again. Then there is no or less likely spontaneous change in cardiac output or VTI that may occur. I agree with you otherwise.
Yeah, I think we have no more times, or we just have maybe another 3 or 4 minutes for the discussion to end. I have a question among the attendees for Dr. Daniel Einstein. Someone is asking if there is way by lung ultrasound to differentiate between what you call it hemodynamic pulmonary edema or cardiogenic pulmonary edema and alveolar hemorrhage. Is there any way to differentiate both?
Do you hear me?
Yeah.
Yes. So hemodynamic pulmonary edema, I see it since 3 decades. I can speak of it.
Okay.
Alveolar hemorrhage. I am ashamed to say that I do not see that daily in my institution. And I speak only of what I have seen myself. Unfortunately, I was not there the day where we had alveolar hemorrhage.
Great. Maybe you agree with me, Professor Daniel, that a lung ultrasound or echocardiography or any sort of critical care ultrasonography has to be put on the context of history, clinical examination, and everything. And particularly, there are certain things that we cannot find as specific things to diagnose, like alveolar hemorrhage might present with a sort of interstitial changes that gives you confluent B lines. And this is, if you put this among the clinical history and other physical examinations context, you might reach the diagnosis. But in a minute or less, because I was very interested in this point and I wanted to ask you personally, if there any rule for color Doppler or Doppler in lung ultrasound to diagnose different types of pneumonia in very short time.
In a very short time, I let people use Doppler if they like it, but I don't.
You
That's
don't.
a very short answer.
You don't recommend, you don't have.
I don't use it.
You don't use it. Okay. Thank you very much.